Thank you very much. And even though, as Lei already mentioned about, so we are planned to incorporate some of the molecular data to the 10th edition of the TNM. However, my presentation is the pathology perspective. So because I was asked the pathology. So this is my disclosure. And in addition to the TNM pathologic TNM stage, the, because the pathology TNM system is major, the extent of the tumor microscopically, histologically. However, some of the factor determine may change the TNM stage. One is the invasive size and extent of the visceral pleural invasion. And of course, the nodal status, especially isolated tumor cell, if the tumor cell is a 0.2 millimeter, that's not nodal metastasis. But in case of the 0.2 to 2 millimeter, that was called as a micrometastasis, and that was N1. And also the distinction of the double primary and the intrapulmonary metastasis, that would be one of the big challenge of the pathology factors. In addition to these factors, we were going to talk about the three factors as shown here. The one is the GGO and histological grading and stats spread through various species. I'm going to talk about the three factors. So first, the GGN and the lipidic growth. So we have already discussed about the GGO. As you can see, the clinical T and the pathologic T is defined by the GGN and TN lipidic growth. So this is a typical example. You can see in the left the CT image, and right is histological features. So in histological features, this is a range of the tumor. This GGO region corresponding to these areas. So we have already discussed about the tumor with the GGO. We call now is a non-solid. Subsolid nodule has shown to be a better prognosis. This is one of the paper from our JCOG study. So you can see when we compare with the subsolid nodule and the solid nodule, you can see there's some differences in prognosis according to, even though we account for the stage differences. So this kind of the data has been already published, and this is a list of such data. Even though some of not support a better prognosis in the GG subsolid nodule, however, most of them show a better prognosis. So this is the characteristics, summary of the characteristics of this kind of the tumor. Subsolid nodule have a higher prevalence of the female non-smoker adenocarcinoma, frequent EGFR mutation, and less aggressive clinical cause. In contrast, solid tumor show a higher frequency of the smoker and the KRAS mutation. The KRAS mutation is closely associated with the smoker, and more aggressiveness has been in comparison with the subsolid nodule. So there are many papers showing this kind of the tumor may be a different disease in terms of the non-smoker and the smoker, and women's adenocarcinoma or male lung cancer, and also the never smoker is the most is a matter of the discussion. And this figure So one of the explanation of these differences can be explained with the model for lung cancer development. So this is taken from the WHO classification of the lung cancer. So lung can be divided into the central two anatomic component. One is the central airway compartment, and that's conducted the air to the parenchyma. And the parenchyma is called the terminal respiratory unit. And of course, the central airway compartment is more susceptible of the smoking and the repeated exposure of the tobacco carcinogens that's caused to the accumulation of the genetic automation as well as the escaping from the immune surveillance against the neoantigens. So probably the small cell lung cancer, squamous cell carcinoma, and some kind of the solid tumor have this kind of the cancer development. In contrast, EGFR and ALK is shown to have never shown to develop in the never smokers. Probably the driver alternation of this powerful transformation activity directly cause the tumor. Therefore, TNM's tumor mutation burden is low and immune checkpoint inhibitor are not so effective. So therefore, we were going to address the TNM classification, this kind of the GGO or lipidic component in the 10 edition using a database. And the next would be a histological grade. I-ELCAP Pathology Committee released histological grading for adenocarcinoma. And that was validated with the many articles. And I would like to show the one of the result. You can see this grading is closely associated with the CT finding. As you can see, the grade 1 tumor have a higher frequency of the GGO or parasolid nodule. In contrast, the grade 3 is account for mostly a solid nodule. And actually, this grading system is used in a clinical trial. This is a study design of the ADORA-2. And you can see here that was used for this histological grading is used for patient stratification. And as a result, some of the patients have a higher benefit. It may have a higher benefit in the high risk group. So that's in that time, the histological grading may have more focused. And this histological grading can be predicted by the PET SUV max. So the histological grading associated with the PET CV max, so you can predict using a PET. Lastly, I'd like to touch on the spread through alveolar spaces. So you may know that STAS is one of the invasion pattern to the alveolar spaces because the lung is the only organ which has alveolar spaces. Therefore, this STAS invasion pattern is recognized only in the lung. And this is repeatedly reported as a predictor of the poor prognosis, especially higher risk for recurrence in a limited resection. And this is in such an example. You can see the list of this publication. However, most of them are retrospective study. Therefore, using the JCOG 0807, we are going to, I-ELCAP committee are going to examine with the clinical significance using this prospectively corrected material with the member. So this is a summary of my talk, and the pathological factors are the basis of the patient stratification in the current staging system. additional purposing factor I show in these three is now exploring to the upcoming staging system. Thank you very much.